Hello guys. So let us now start with general surgery. So in general surgery, we'll go on with all the materials that we use for our surgeries. Okay. So starting with catheters, there is central vein that you guys should be aware of. That is one is SVC central line and another one is IJV central line. SVC central line, SCVA central line, we use it for TPN, that is total parenteral nutrition, whereas IJV we generally use for trauma patients. Okay, then coming to Foley's catheter. There are two types of Foley's catheter that you guys would have known in your internship. So one is latex Foley's and another one is silicone Foley's. So silicone we use for long-term patients, whereas latex for short-term management. So one French is equal to 0.3 millimeters and 1 millimeter is equal to 3 French. Okay, 1 mm is 3 French. I mean, one millimeter will be 3 Frenches. Okay. Then coming for feeding, so if we are doing less than 4.6 weeks, we are going to use NG tube. If the management is needed less than 4.6 weeks, we are going to need NG tube. Whereas more than 4 to 6 weeks of parenteral feeding is needed, then we are going to go for PEG tube. Okay. So remember this, NG tube is less than 1 month, and if it is more than 1 month of management, we are going to go for PEG tube. So all the cannulas are very important. Please remember two cannulas, that is high flow and the low flow. Okay, so 14 gauge will be orange and high flow rate will be 270 millimeter, and low flow 24 gauge yellow, which will be 20 millimeter 20 milliliter per minute. Okay, so other things you will be knowing during your internship, right? So we used to use green usually for everyone, so that is 100 ml per minute. So this is 18 gauge, whereas pink for kids we used to use it is 20 gauge. Okay. Then coming to blades that we use in our surgeries. So remember, 11 blade is a sharp ended. We used to use it for incising and draining. Okay, so for draining some abscess or something, we used to nick it, right? So after nicking, the pus used to come out. This is 11 blade that we use. Then the 12 blade is for suture removal. We used to do this suture removal post orthopedic surgeries, and we used to use in obstetrics, right? Post C-section suture removal we used to do, right? So these things, the 12 size. Okay, then 10, 15, 20 and 23 for other incisions. Okay, so in incisions, please remember two words. Okay, that is Langer's line and Blaschko's line. Okay, what are these two? Please don't confuse Blaschko's line with Langer's line. Langer's line is the skin crease. Okay, so along the skin crease only we try to give our incisions. Okay, to reduce the scars. Okay, and for better healing. Whereas there is something other thing called as Blaschko's line, where the embryological genesis of this skin and all will happen. Okay, so this is a different thing. Okay, so don't confuse Langer's line with Blaschko's line. Okay, moving on. So let us move on to the other main material that examiners have been keen in asking is suture materials. Okay, so there are two types of suture materials, that is absorbable sutures and non-absorbable sutures. Okay, in absorbable suture and non-absorbable, it is two types of classification, that is synthetic and natural. Okay, so absorbable natural suture is catgut. Okay, please remember catgut. Okay, so one of the variant is chromic catgut, which we use it for tubal ligation. Okay, vasectomy after fallopian tube ligation and all these things, we use this catgut. And main catgut usage was we used to use it in circumduction, right? So final year question. So final year practical question, catgut we used to use, right? So remember that thing. It is an absorbable. And coming to absorbable synthetic, it is going to be monocryl, vicryl, PDS, and Dexon. Okay, so remember these names. Then coming to non-absorbable, natural, it is going to be silk, black color, right? So it used to be black color. Then coming to synthetic, it is going to be nylon, prolene, novafil, and polyester that we use. Okay, so these are non-absorbable synthetic. Then coming to suture removal, for scalp, it is gonna be 5 to 7 days. See, for each region it is different. Okay, so this is a question that I saw in a question bank, so please be aware of this. That is, for scalp it is gonna be 5 to 7 days, whereas for face suture removal it is gonna be 3 to 4, after 3 to 4 days we remove the suture. Okay, now moving on further, we'll go on to anesthesia. Okay, so this is more than enough for anesthesia. See, some of the extra points that you want to learn, you please learn it from the question banks rather than going into learning the anesthesia chapter itself, because it is vast and we wouldn't know what type of question anesthesia they would be asking. So that is why please learn it from question bank. Okay, so anesthesia, I'll give you the general basic ideology behind anesthesia. Okay, so there are 4 kinds of anesthesia that we do. That is general anesthesia, regional anesthesia, local anesthesia, and sedation. Okay, so these are 4 classifications of anesthesia. In general anesthesia, it is gonna be usually IV and inhalational general anesthesia. Okay, so IV general anesthesia is what we start with, right? So this is what we are gonna start with, whereas inhalational we use it for maintenance. Okay, so when we used to go to like anesthesia postings and all, or in any general surgery postings, we used to see, right, first they used to induce the patient, and then the mask was placed, and the maintenance was done through inhalational anesthesia, right? So IV general anesthesia, it is gonna be propofol, ketamine, and all these drugs, right? But so these are the important drugs. Okay, please remember only one example from each. Okay, so propofol, ketamine, all these things for IV general anesthesia, whereas inhalational, they used to give sevoflurane, right? So sevoflurane through the mask they used to give. So remember in that way. This is inhalational general anesthesia. What is the mechanism of action? So propofol and all these IV general anesthesia, most of them mechanism of action is same. That is, they'll increase the chlorine entry and increase the GABA receptor. What is GABA? GABA and glutamate we discussed, right? GABA is an inhibitory, right? So it inhibits the action potential. Okay, so inhibits the action potential, meaning so there won't be any action that is happening in the body. So that is why we'll go numb and we'll lose the consciousness. Okay, so this is the mechanism of action behind it. So this reduces the GABA, whereas the inhalational anesthesia is also similar one. So it is gonna increase the GABA and decrease the glutamate. GABA inhibitor is there, glutamate is the excitatory hormone. It will reduce the action of glutamate. So that's it. Okay, so usually general anesthesia similar function, that is increase the GABA action. So coming to regional anesthesia, it is gonna be spinal anesthesia, nerve block, and another one is local anesthesia. Okay, so there are 2 kinds of regional anesthesias, that is amides and esters. Okay, so both of them have a similar function, that is similar mechanism of action, that is reduce the sodium influx and reduce the action potential. We discussed, right, in general physiology. So sodium influx was the first thing that was happening for action potential to generate. So if there is no sodium influx, how will the action potential get generated? So this is the mechanism of action for general anesthesia, regional anesthesia. That's it, right? Here in general anesthesia, we used to increase the inhibitory action potential, whereas in regional anesthesia we are gonna reduce the sodium influx and thereby will reduce the action potential. Okay, that's it. Then some of the important things that I want you guys to know is there is something called green whistle. Okay, you would have seen in if you football and other athletics. So they use inhaled analgesics immediately. A green pen will be given, and this is a green pen. Okay, so the green pen will be given to the athlete, and suddenly he starts taking inhalational breaths from that pen. Okay, so after a athlete falls, or suddenly when the paramedics come in to the field, so they give a green pen. Okay, so this is nothing, this is called green vessel in a common name, but what does it contain? It contains methoxyfluorine. Okay, so this is an analgesic that they give. Okay, so this is an inhaled analgesic, which is very fast acting, so that is why they use it in sports and athletes. Okay, so remember that one point. Okay, then coming to one of the major topic, and so all the exams they have been asking this thing. Okay, so that is malignant hyperthermia. What happens is, so let us see the pathogenesis first. What happens is there is something called RYR1 mutation. Please remember this RYR1 mutation. Okay, so RYR1 mutation, what it does is in succinyl, for example, so a patient is having a RYR1 mutation, and we give succinyl choline. Okay, so the inducing agent, what happens is there is increased calcium influx and sustained muscle contraction will be there in these kind of patients. Okay, so if a sustained muscle contraction is there, all the ATP gets used, and ATP gets depleted, and also there is increased heat production during this sustained contraction. Okay, so the patient suddenly collapses during the surgery itself. So when we do the investigations, so this is what we'll find. Okay, so malignant hyperthermia, please remember this. Okay, what is the management? It is going to be dantrolene. Okay, so remember this name, dantrolene. So this is malignant hyperthermia. So examiners have been interested in asking this question. So other thing with regards to anesthesia, I want you guys to learn is, with regards to anesthesiology, we do intubation, right? So during intubation we use laryngoscopy, right? So there are two kinds of laryngoscopy, that is Miller's and Macintosh. Okay, Macintosh. Okay, so I want you guys to know the difference between them. So Miller is a straight blade. Okay, straight blade it will be there. Okay, so straight blade it will be there, whereas Macintosh will be a curved blade. Okay, so curved blade will be there. Okay, so in Miller's blade, we generally use it in a laryngomalacia and all these patients where we have to go behind epiglottis. So for example, let us take this as tongue, and this is epiglottis. So what we do is we'll put the blade directly behind the epiglottis and lift the epiglottis to visualize the larynx. Okay, or the vocal cord. But in Macintosh what we do is, so between epiglottis and the tongue, so we put it in the vallecula. Okay, just behind the base of the tongue, and in between the epiglottis we put the Macintosh blade and lift the epiglottis and visualize the vocal cord. Okay, so this is what we usually do in all the adults and all, but Millers we use it for kids with laryngomalacia. Okay, so I want you guys to know an extra point with regards to laryngoscopy. Then now that we have learnt all the materials and all we require in a general surgery, so let us move on to the specifics of surgery. So okay, so now let us start with trauma. Okay, so in general surgery these are the things that we see, right? The other specifics of surgery we'll talk about it in each system. Okay, now coming to trauma. triage is the most important thing. So we all get confused with triaging only. So remember, it is a red meaning immediate management is needed, yellow can wait for a little while, whereas green is ambulatory, and the black is he is dead or demised. Okay, so this is the thing I want you guys to learn. uh, some of the things are like perforated bowel and is stable patient will be put to yellow. Okay, so remember this thing, perforated with stable and he is a stable patient, then it will be yellow. Okay, and also someone who is grievously hurt, like open wound is there but he's not bleeding, that will also go for yellow. Okay, so please remember these things. Then moving on further with the trauma, you will always remember the ABCD, right? ABCD is the protocol that we follow, right? That is airway, breathing, circulation, disability and exposure. Okay, so these are the things that we check for when a patient arrives. Okay, then coming to abdominal injuries. Okay, so each trauma will discuss here. So starting with abdominal injuries, if is an unstable patient, that is BP, pulse rate and respiratory rate is abnormal, then what we are gonna do is fast and then directly go for laparotomy. Okay, fast and laparotomy in abdominal surgeries. Okay, we'll do fast and then go to laparotomy. Sometimes we will even go to direct laparotomy instead of going for fast. Okay, so check for that in your options. So sometimes the patient might have to go to laparotomy when the signs are very obvious. Suppose a patient has come with the obvious peritonitis signs, then we'll have to go directly for laparotomy instead of even waiting for fast. Okay, so this is the thing I want you guys to remember. Whereas in stable patients, we'll go for fast first and then we'll go for CT. Okay, so we'll go for CT. Yeah, if the fast is positive, also they will go for CT. If the fast is negative, also we'll go for CT. Okay, if he's a stable patient, and this is the investigation of choice that we do in an abdominal trauma. Okay, remember that. Then some of the important points are that is in abdominal viscera or hard organ injury. So this is a general thing I'm telling you. Okay, so grade 1 to grade 3, we grade the injuries, right? So based on how exactly the organ looks like, based on a CT and based on USG. I mean fast technique. What we'll do is we'll try to grade the organs. Okay, whether it is shattered, only the hilum is injured, or only if there is only the capsule that is damaged. So we grade based on this. Okay, so grade 1 to grade 3 we generally observe. Okay, we'll do the, you remember, right? We used to do in general surgery postings. If there is a trauma patient, we used to measure the abdominal girth hour by hour. PGs used to make us stay there, and we used to take the girth size, abdominal girth size. This is what we used to do. That is grade 1 to grade 3 we generally observe. Whereas grade 4 and 5, that is, for example, if it is if the organ is shattered, we'll go for splenography on that or that specific. For example, splenography or splenectomy, we do it. But for example, if it is a renal injury or if it is a liver injury, so same here also, it is going to be hepatectomy or entire renal tissue removal. In that way we do. Okay, so grade 5, grade 4 and grade 5, it is going to be this management, whereas 1 to 3 it is going to be observation. So coming to one of the specific points for splenectomy is the prophylaxis that we give for before splenectomy. Okay, so because after it is a lymphoid organ, after removal of it, they will be immunocompromised. So that is why it is good to give prophylaxis, which we used to always do in our hospitals, right? So emergency, if we are doing an emergency splenectomy, then we will be giving 2 weeks after the surgery. Okay, whereas if it is an elective splenectomy, then 2 weeks before splenectomy we will be giving it. Okay, so what are the components of for the prophylaxis, it is going to be the vaccine that we give is, it contains staph pneumonia, then Haemophilus influenza B, then Neisseria meningitidis. Okay, so these are the vaccines that we give. Then we'll move on further with pneumothorax. Okay, so pneumothorax is like air in the lung field, right? So how we manage is very important, and examiners have been interested in asking this. Okay, so GCS is the first thing that we see. Okay, so in question, if they have given GCS, go decide based on the GCS. Okay, so more than 8, if the GCS is there, it is going to be a different type of management, whereas less than 8 is there, we are going to go for a little extra step. Okay, so let us see what is it. If the patient is unstable, same as like we discussed in trauma, right? So with respect to abdominal injury, here also it is same. So if the patient is unstable, we are going to go for immediate management, that is needle thoracostomy is what we are going to do. Okay, if the patient is unstable, BP, then the pulse pressure and respiratory rate difference is there, then it is going to be unstable patient, and we are going to go for needle thoracostomy. Whereas if GCS is high and if he is a stable patient, we are going to go for ICD drainage. Okay, so ICD drainage is what we are going to do. Okay, but if the patient is having less than 8 GCS, first we will do the intubation, because airway is what we are supposed to secure, and then we'll go for breathing. Airway is first secured, and then we'll go for breathing management, right? A, B, C, D. It means that A first and then B, right? So in GCS, the airway is also compromised, so that is why we'll first intubate them, and then we'll go for ICD, the specific management. Okay, so there is no point in doing the needle thoracostomy, we'll go for ICD. Okay, so triangle of safety is where we do the ICD, right? So the triangles of safety is, it is between fifth intercostal space and two major. What is the triangle? So it is the two majors, that is latissimus dorsi and pectoralis major. Okay, so this is the axilla, right? So in the axilla region, so this is latissimus dorsi from behind, and this is pectoralis major in the front, and it is going to be fifth intercostal space. That is the triangle that forms, and here we usually do the ICD drainage. Okay, in the mid axillary line. Okay, so this is the point I want you guys to learn with respect to pneumothorax. Then what are the types of pneumothorax and all, we'll discuss in pulmonology. Okay, then moving on further, burns. Okay, so there are grades of burns, that is there are four grades of burns. Okay, the first grade is it is epidermis that is involved, and the features will be red swelling and pain. This is normal hot burn that we will be having, right? When we are cooking or we are heating something, if we get a burn, so that it is definitely gonna be first degree burn. Okay, so then moving on to second degree burn, it is the superficial dermis and deep dermis that is involved. Okay, so it is quite a little larger than first grade, first degree burn. So it is going to be presenting with blisters, and it is going to be painful. Okay, then coming to third degree burn, it is going to be complete dermis, where the necrotizing material can be seen, whereas if it extends till bone, it is going to be carbonization feature, that it is going to have all the charring and all. Okay, so it extends till burn. Okay, so in a patient who is burnt, I mean to that extent, we'll use virtual technique for autopsy. Okay, please remember that for fourth degree burn, if we are doing an autopsy, if the patient is dead, we are going to go for a virtual technique of autopsy. Okay, please remember that extra point. Then how do we manage the patient? Managing the patient is based on the percentage of burn. So how do we give the percentage of burn? It is based on rule of 9, right? We remember this since our final year. That is generally for all the adults, this is for adults. Okay, for the kids value, we go see an image of the kid. Okay, so the rule of 9 for head, neck and face, it is gonna be 9%. Then for each arm it is gonna be 9%, anterior trunk 18%, then posterior trunk 18%, legs, each leg is gonna be 18%, then the perineum is 1%. Okay, so please remember these values. Okay, please paste it this in your sticky note. Okay, so that's it. So how do we manage after that we have decided that particular burn percentage is there? Is if it is a less than 5% of burn, it is going to be a minor burn injury, whereas if it is more than 5%, we consider it as major burn injury. Okay, so minor burn injury, we used to manage in OPDs, right? So this is gonna be, we'll clean the area, then we'll use silver sulfadiazine. Okay, so we'll use silver sulfadiazine and antibiotic that usually be bacteriacin ointment or mupiracin ointment or fusidic cream. Any of this we can use. We used to generally use this in our hospitals, right? So in general surgery management. Okay, then we'll do the dressing and send the patient home. Okay, if you wanna keep them for observation, we can also keep them for observation. This is an OPD management. Whereas if it is a major burn, then we'll follow a protocol called BATLS. We need not need the uh, like the abbreviation for it. Remember, BATLS. Okay, so this thing we use, and for analgesics we use morphine. Okay, like for all the patients it is not required, only SOS. Okay, so this is SOS. It is not a protocol that we follow. We are giving morphine to everyone. It is gonna be SOS. Whoever is in too much pain, so we'll be giving morphine. Okay, so morphine is choice of drug. Okay, then Parkland formula is very important for the management of fluids, because we are gonna manage the patient with fluids, right? So Parkland formula will be 4.2. Okay, this is a specific value. Okay, 4.2 into weight of the patient into percentage of burn. Okay, so this is the amount of fluid that we use for the management of a burn patient. Okay, then after the fluid management, we'll go for cling film dressing. Okay, so this is what we do in a major burn patient. Okay, so after all this thing, we'll go for TT vaccine. We'll ask the patient's TT vaccine status. If needed, we'll go for TT vaccine. Okay, that's it. So this is all the thing that you guys need to know just before going into exams with regards to burns. Okay, now moving on to the further topic, and that is very important, that is shock, right? So what is shock? It is nothing but a reduced tissue perfusion. Okay, tissue perfusion, the blood is not reaching or there is no too much blood that should reach the tissue. Okay, so that is why there is no tissue perfusion. If tissue perfusion is not there, then there will be reduced oxygenation of that particular tissue, right? So this is what happens in shock. This is shock. Don't confuse shock with anemia, because anemia is different and shock is different. Here the tissue perfusion is affected, whereas there the hemoglobin system is affected with respect to anemia. Okay, so the oxygen carrying capacity is affected. Here the oxygen carrying capacity is normal, whereas the blood flow itself is affected. So that is what is the difference between shock and anemia. Okay, so the four main types of shock is hypovolemic shock, cardiogenic shock, then obstructive shock, and distributive shock. So what are these? Hypovolemic is blood loss. Okay, so we are losing the volume of blood. Okay, so more than 30 to 40, more than that amount of volume percentage is lost in the blood, meaning it is going to be hypovolemic shock. Whereas cardiogenic shock is pump failure. Okay, please do not confuse cardiogenic shock with obstructive shock, because both of these shocks heart is involving, and we'll definitely get the confusion between cardiogenic or obstructive shock. If it is a pump failure, for example left ventricular failure and all these things is there, then go for cardiogenic shock. Whereas obstructive shock is there is mechanical obstruction to the flow of the blood. For example, let us take aortic stenosis and all these things is there, right? So if there is a HOCM, here there is a mechanical obstruction to the flow of blood, so that is why the blood flow is decreased. Okay, so this is what the obstructive shock means. Then coming to distributive shock, there are two types, that is neurogenic and septic shock. Okay, neurogenic shock is sympathetic loss. Sympathetic loss meaning, see, sympathetic we had discussed in general pharmacology, right? So sympathetic was supposed to vasoconstrict. If the vasoconstriction is not there, the blood flow will not be proper, because the vessel is dilated and there is no enough pressure for the blood to reach the tissue. So that is when, if the sympathetic system is lost, then it is going to go for neurogenic distributive shock. Whereas septic shock, there is again same thing only, but is a different mechanism. Here there is increased vasodilation and there is increased leakage, right? So there is sepsis, so that is why there is leakage. We had learned this in our pathology, right, with respect to inflammation. So there is a cascade of reaction, that is a vascular event, cellular event. There are 4 stage, that is margination, all these things, right, we learned there. So this is what is happening. So there is increased leakage, so there is no enough blood volume here, all the fluids have been leaked out, so there is no enough pressure inside the blood, so the blood cannot reach the tissue. So that is distributive septic shock. Okay, so infection and all these things will cause endothelial leakage. Okay, so this is the thing I want you guys to remember. Here the specific points are, in cardiogenic and obstructive shock, the JVP will be elevated. Okay, because here the heart is involved, right? So remember in that way. So JVP will be elevated, whereas in all the other shocks, it is going to be JVP reduced. Okay, so this is the thing I want you guys to learn. And in all the other shocks, it is going to be heart rate increased, whereas in neurogenic shock, because sympathetic system is lost, so that is why low heart rate. Okay, so remember, low heart rate with respect to sympathetic distribution or neurogenic distributive shock. Okay, so this is all with regards to shock. Okay, now coming to the two most important topics, that is vascular surgery, that is arterial occlusions, and then coming to veins, venous pathologies, that is DVT and varicose vein. Okay, so the two most important thing will be covering here, and will be done for general surgery. Okay, so what is it? In vascular surgeries, we'll start with arteries first. Here the main thing is arterial occlusion. Okay, so there are two types of arterial occlusion. It can be acutely occluded or chronically occluded. Okay, so if it is acute occlusion, then it is going to be pain, pallor, pulselessness, paresthesia, and poikilothermy and paralysis. Okay, so these are the 6 P's I want you guys to learn. Okay, so pain, pallor, and all these things. Okay, so these are this is how the patient will present with. Okay, so there is just too much pain and pallorness will be there around whichever the artery that is occluded. Okay, so what is the management that we do? Artery, right? So that is why antiplatelet. Oh, remember, right, in hematology we discussed antiplatelet, because it is an artery that we are dealing with. Okay, so if it is a vein, we are going to go for anticoagulant. So that is the difference. Okay, the antiplatelet drugs we are going to use, there is something called Fogarty's balloon. It is nothing but like dilating that particular artery. If not, we'll go for embolectomy. Okay, we'll go and remove that emboli. Okay. Okay, then coming to chronic arterial occlusion. So we know that, right, intermittent claudication, it came in our final year exams though. So this is going to be intermittent claudication. Okay, Boyd's classification is what we use, right? So it is going to be 1, 2, 3, and 4 type of Boyd's classification. So please remember all these things. Okay, so with respect to Boyd's classification, Please note this down in your sticky note also. So first will be relieves on walking, whereas second will be walk with the pain. Then for the third stage it is going to be they will compel to rest. In fourth stage it is going to be pain even at rest. Okay. Then the investigation of choice would be duplex and Doppler scan that we used to do, right? So this is the investigation of choice, and also a ankle brachial pressure index. Okay, so 0.9 to 1.1 is the normal ankle brachial pressure index. Okay, so it is the ratio that we take between ankle and brachial BPs. Okay, so that's it. Then coming to gangrene, we had discussed about necrosis in general pathology, right? So this was the perfect place where we discuss about gangrene. So it is going to be dry gangrene and wet gangrene. So the main difference between dry and wet is, in dry there is a clear demarcation and the bone is also involved, okay, with respect to dry gangrene, whereas in wet gangrene there is no demarcation and the bone is not involved. Okay, so this is the major difference between these two. Then the other thing with regards to artery pathologies is the aneurysm. Okay, aneurysm and aortic dissection is very, very important, and in all the exams they are interested in asking this, that is the critical diameter. Okay, so based on critical diameter, how you are going to manage is what they are asking. Okay, so critical diameter in an abdominal aneurysm is 5.5 centimeter, meaning there is an aneurysm and we are measuring the size of that aneurysm till 5.5 centimeter. Okay, so we are going to do nothing. Okay, so this is the critical diameter. Okay, so past that we are going to go for management. What is the management? That is EVAR, open repair and Mattox surgery is what they use for the specific management of aneurysm. Okay, EVAR, open surgery and Mattox repair. Okay, so what exactly is an aneurysm? So it is bulging out of an artery. Okay, so we'll discuss more about this when we go to neurology, where it is very important with respect to stroke and all. So just for now, so aneurysm is like bulging out or ballooning out of the artery. Okay, so then the next topic would be aortic dissection, because the reason why I told you aneurysm and aortic dissection was, so because it is almost similar, but here the intimal layer is affected. Okay, so what happens is there is a other layer, two layers that is created in the artery itself. So if it is a two layered thing, then it is going to be aortic dissection, whereas ballooning out is aneurysm. Okay, please do not confuse dissection with aneurysm. Okay, then so CT is the investigation of choice, where we'll get to take a look at these kind of CTs. Okay, so that is what, so this is the layer, the intimal layer which has been sliced. Okay, sliced open, and so two lumens will be formed. Okay, so this is the fake lumen. Okay, whereas this is the true lumen. Okay, so this is a pseudo lumen and true lumen. Okay, so this is how aortic dissection would look like. Okay, then there are two kinds of classification, that is Debicki's classification, Stanford classification. Two also you should know. Okay, so because it is very easy, the thing is 1, 2 and A of Stanford is same, whereas 3 and B of Stanford is same. Okay, so the first thing is, if the ascending aorta and the arch of aorta is affected, then it is going to be 1, 2 and A with respect to Stanford, whereas if 3 and B of the Stanford classification is affected, then it is going to be descending aorta that is affected. Okay, so this is with respect to aortic dissection. And so the management of the aneurysm is very important, that is critical diameter of 5.5 centimeter is where we decide whether the patient needs management or not. Okay, so that's it. Then moving on further, the Raynaud's disease, right? So what is the difference between Raynaud's disease and syndrome is primary and secondary. If it is a cold exposure that is causing the phenomenon, then it is going to be Raynaud's disease, whereas there is a secondary underlying issues, that is SLE or rheumatoid arthritis and all these things. So if it is an autoimmune thing, then it is going to be secondary, which is called Raynaud's syndrome. Okay, so Raynaud's disease and syndrome are two different things. Okay, but the management is almost same. That is, we'll treat the underlying issue, that is cold exposure there. Will do the reheating, like the generous reheating is done, and the specific management is calcium blockers. Okay, so this is the thing with respect to Raynaud's disease. So that is done for arterial pathologies. So now moving to venous pathologies, it is going to be DVT. But first we'll talk about, and then we'll go on to varicose vein. Okay, DVT. So remember Virchow's triad, right? Virchow's triad, that is stasis, hypercoagulation, then endothelial injury. This is the triad of Virchow's, which might lead to an increased risk of DVT. So what are the diagnostic criteria? That is, we'll diagnose based on the signs. Okay, so signs and clinical features. So signs will be Moses sign and Homan sign. What is Homan sign? Pain on dorsiflexing the foot. Okay, for example, there is a DVT in the calf muscle. So if we dorsiflex the foot, there will be pain. Okay, this is known as Homan sign. Okay, so remember that. Then there is something called as Felagnacy curella dolens, which is pain in that particular region of the calf. So for example, this is a calf and this particular line is there. So if there is pain over there, then it is called Felagnesia curella dolens. Okay, please remember this name. Whereas Felagnesia alba is nothing but the whitening of that particular region is known as Felagnesia alba. Okay, so investigation will be DVT scoring. Okay, the well scoring will also be with respect to we'll be doing for pulmonary embolism also. Here in DVT also we are doing. Okay, so well score is similar. Okay, so that is if there is a signs of DVT and there is pulmonary embolism, then it is going to be 3 points that we'll give. And tachycardia, immobilization and prior DVT is there, then 1.5 for each of them will give. Then coming to hemoptysis and active malignancy, will give 1 points for each of them. So what is the so basically DVT will give rise to the risk of pulmonary embolism. That is what we are checking here with respect to well score, right? So if it is less than 4, the score is less than 4, the pulmonary embolism is very unlikely. Whereas if it is more than or equal to 4, then pulmonary embolism is likely. So that is how we'll do the prophylaxis management for pulmonary embolism based on DVT scores, okay, or well score. Then the management, specific management is, so it is going to be direct thrombolysis, then we'll give anticoagulants, then after that we'll go for low molecular weight heparin and warfarin together, then we'll go for warfarin specific management. Okay, or else we can use IVC filters, so that if there is an increased DVT, there are too many number of emboli or thrombosis there that we are detecting, we can go for IVC filters, where all these emboli will not reach basically the pulmonary circulation, right? So it can all be filtered out. So this is how we prevent pulmonary embolism from happening. So then moving on to the specific of varicose vein. So basically we all know, right? So it is going to be in long standing people, the bus drivers, teachers, surgeons, all these people with occupational the risk will be having varicose vein. So here Hunter's, Doyd, Boyd and Cockett perforators are the named perforators that I want you guys to be aware of. So for example, let us take this as leg. So Hunter's will be here. Okay, then Dodd, Boyd and Cockett. Okay, so these are the named perforators. Perforators are nothing but they are connecting the superficial and deep vein. So these connection between two veins is there, right? So those are called as perforators. If that is if it fails, the varicose vein will be happening. So that is when the vein will have the clinical features of varicose vein. Okay, so the main thing is classification, what they are interested in. So classification is based on CEAP, right? So C belongs to clinical, then E is etiology, anatomy and pathophysiology. Okay, so see as 7 types of classification. That is, if it is C0, no features of varicose vein will be there, and C1 will be telangiectasia, that is less than 1 mm of the diameter of the varicose vein, whereas the C2 is varicose vein, that is more than 3 mm. Then edema with C3, C4 is lipodermatosclerosis, that is the eczema and all that we see. For example, this is the foot region, so here we get to see all this early eczema and all, right? So this discoloration is known as lipodermatosclerosis, which is C4. Okay, then coming to C5 is healed ulcer, whereas C6 is active ulcer. Okay, so if it is active ulcer, we are going to be giving C6. Okay, so ulcers will be most common in this same region, that is Gator's area. This is called as Gator's area. If the ulcer becomes complicated, it is going to become Marjolin's ulcer. Remember it, Marjolin's ulcer. And this Marjolin ulcer is nothing but squamous cell carcinoma. It is going to complicate into squamous cell carcinoma. Okay, that is what we discussed in dermatology also, right? So squamous cell carcinoma, the major risk factor is ulcer. Okay, so ulcer is what transforms into squamous cell carcinoma. Then coming to etiology, it is going to be either congenital, primary or secondary etiology. When coming to anatomy, it is going to be, we discussed, right, the perforator, superficial and deep veins. So that is the thing, we'll divide them whether what is affected. So superficial vein is affected, or deep vein, or perforator that is being affected here. Then coming to pathophysiology, is it the reflex that is affected, or there is any obstruction in a vein that is causing the varicose vein, is the pathophysiology behind this CEAP classification. Okay, so you finally got it, right? So just go and paste this C thing in your sticky note. Okay, just before going to the exam, you can see, and you wouldn't be confused with what is presenting what. Okay, that's it. Then coming to management, the investigation will be USG will do. So, and all the diagnostic tests we remember, right? We'll raise the leg, all the Trendelenburg test and all these things, right? So if you want, go through that once in any of your surgery practical books. So then investigation will be Mickey Mouse sign. So a DVT would look like this, something like this. The varicose vein would look something like this. Okay, so Mickey Mouse sign will be there. Then coming to management, if it is a telangiectasia and all, so I will go for sclerotherapy. That is Tesserae technique is what we use for sclerotherapy. And now we are not doing stripping and all, so it is going to be advanced way, that is laser or radio frequency management that we use, RFA and EVLT. Okay, so laser management and radio frequency management is what we do now. Okay, so previously when stripping was done, or now for example for CABG and all, we still do stripping, we remove the vein, right? So that is when there might be some injuries. Okay, for CABG, that is for the bypass graft, we usually take saphenous vein, right? So if a short saphenous vein is affected, then it is going to be sural nerve injury, whereas if it is the great saphenous vein that is affected, then it is going to be saphenous nerve injury. Please remember this injuries. Okay, please do not confuse between them. Okay, short is on the lateral side, whereas the great saphenous will be on the medial side, that is why the saphenous nerve injury. Okay, so remember this thing. So that is all and everything with respect to veins and arterial pathologies. So vascular pathologies are done. So now one of the important topics is with respect to general surgery is all the scores and the post surgical management. So now, so it was in that way only I taught you. That is, first I taught you all the instruments that are required for the surgery. We discussed about anesthesia just before the surgery that we give. Then the specific general surgeries that we do or manage with the department of surgery, that is trauma, burns, pneumothorax, and shock. Then vascular surgeries, all these are with respect to general surgery, right? So we discussed all the main surgeries that are required. Now we are going for after surgery, what we do, post surgical care that we do. Okay, post surgical care. So two things I want to know, want you guys to know is about the feeding and the ERAS protocol, the new thing. Okay, so total parenteral nutrition in some of the people we follow, right, post surgery. So what happens is here when we use that TPN solution, so there is zinc defect in that. Okay, so that is why zinc should be supplemented. There is no zinc in that particular solution or the bag, TPN bag that is there. Then there is also called fat free TPN, where we use this fat free TPN in jaundice and fatty liver people, because we are trying to avoid fat again, right? So we'll discuss more about this when we go to gallbladder pathologists. But for now, remember, fat free TPN, jaundice and fatty liver patients will give. Okay, there is something called refeeding syndrome. We also discussed this in pediatrics, right, with respect to management of severe acute malnutrition, where there is electrolemia, that is hypopotassiemia, hypophosphatemia, and hypomagnesemia. Okay, so I told you, right, what happens is insulin will sudden, if we start refeeding immediately, what happens is there is increased insulin, and insulin surge is there, all these electrolytes will go inside the cell, whereas there is no electrolytes inside in the blood itself. So what happens is they'll undergo electrolemia and can have cardiac arrhythmias and all. So that is why it is very important that we address this electrolemia first and then go for refeeding. Okay, so that is the thing with respect to feeding. Okay, now the newest thing, that is ERAS protocol, is that this is a new thing. What is happening is we used to have extended stays for the patient, there used to be extended recovery, rehabilitation, and all these things, right? So now the surgical team, or the world surgical team has finally decided that what is the proper protocol that should be followed for that particular patient and that particular amount of management. Okay, so this is the general way that they are managing in every hospital to reduce the extent of stay and extent of recovery. Okay, so what happens is, how we manage is from pre-operation only this thing starts. That is, pre-operatively up until 6 hours the solids can be given, and 2 hours, until 2 hours the liquids can be given. And glucose load is done. Okay, pre-operatively glucose load is done, and there is no bowel prep. We used to give enema and do the bowel prep and all that, right? So now that has been stopped. Now till 6 hours the solids can be given. It is not like overnight fasting you do. After night eating, we are not telling them to not eat at all. Okay, so and till 2 hours also there is no NPO protocol that is being followed. Okay, so remember this ERAS protocol. Then coming to operative management is minimal access, that is all the laparoscopic things and robotic surgeries that has come up. And then coming to maintenance fluid is also given. Okay, so for enhancement of recovery. Then post-op, it is going to be early feeding that we initiate, just even after big open heart surgeries also. Now they are giving within after the patient starts regaining the consciousness itself, we are starting the refeeding. Previously it used to be all the IV things only. Okay, that is what, discontinue the IV. So immediately we'll discontinue the IV also, and we'll start refeeding the patient, and also to avoid refeeding syndrome also. Okay, then early catheter removal to avoid all the infections is what we do. Okay, so this is ERAS protocol. Okay, then one more specific thing in post surgical management is with regards to bed sores. So the stages and the images, please go through the images of all the stages. That is, first stage will be red skin, only red skin can be seen in bed sores. So that is why all the, in general surgery we used to go and check for bed sores, right, for long stay patients and all. So red skin we see, because always they'll be lying down, and they might the blood pooling will be there, and it can undergo bed soring. Okay, so this is called bed sores. Okay, ulcer might happen in the skin. So red skin will be there, whereas in second stage blisters will be there. Third stage will be subcutaneous or subcutaneous fat is seen, whereas in the fourth stage muscle and bone is exposed. Okay, so these are the four stages of bed sores. Coming to scores, okay, so I've given all the scores, and here I'm not going to explain everything. So there is a chart at the end of the PDF, so please go through the scores, okay, so all the scores just before going into your exams, okay. So this is all and everything you need to know with respect to general surgery, okay. All the specific surgeries, that particular systems and all, will discuss in systemic topics, okay. Thank you.